Hi, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. We're really excited to have everybody this week. I mean, it's been a busy week. We're at the holiday season kind of peak. I just found out from our guest that not exactly the same peak in Canada that it is in the US, with us having the whirlwind of Thanksgiving, finish your turkey, then get the tree up as fast as possible and get ready for all those holiday kind of components. How's your household right now, Donna? Are you guys in the Christmas spirit and switching things and decorations around?
It's in transition mode right now for sure. So getting there, but can't wait till it's through the transition.
Oh, I know. And I feel like the other transition, is it December 21st, I think, is like the darkest day of the year. Like there's the least amount of light, right? And so one difficult transition, at least for us, and I was laughing off screen here, is usually this is a great time of year to get sick in one way, shape, or form. So that decreases our sleep. We are traveling quite a bit, so we're getting less sleep than usual and sleeping in other beds than we're typically used to. So having someone that is a sleep expert to be able to join us is what a perfect time of the year. There's our Medlist Christmas gift to everybody.
Yes, absolutely. And also, it keeps you up at night too, is what you should get for your significant other.
This is true. Yeah. How do I solve that Rubik's Cube of the perfect gift? All right, everybody, we'll start this episode and get rocking and rolling. All right.
So, hi, David, and so excited to introduce you. So today we have with us Dr. David Gardner. He is a professor in the Community Psychiatry Research Director with the Department of Psychiatry at Dalhousie University in Halifax. And I'm just so excited that you're here with us. We had met in France at the International Conference on Deprescribing, and what a great way to meet you, because you spoke so much about sleeping well and the research that you do. So he's the co-developer of the Sleep Well Research and Knowledge Mobilization Program, and just so much research. And I loved the component where you had an actual patient that you had treated and brought him on, and just were able to share how impactful what you do is to the individual patient. So thank you so much for being with us. And I'd love for you to share a little bit about what you do and how that patient got involved with your work.
Everything could be a long story, so I'll have to try and think of giving us a chance to really chat about things. Well, it is nice to meet you both and chat with you again, Donna, because it's been since late September, and now we're very close to the shortest day of the year. Yes. I always love the shortest day of the year because once it's passed, it's just all optimism. We're moving to longer and longer days right after that. My family says I talk way too much about that, but for whatever reason, I like to track that. And we just got our Christmas tree yesterday. We drove down to the South Shore and we actually cut it down, like National Lampoon style, put it on the top of
the roots in the back.
Absolutely. And then drove herself home. So we're ready to, I guess, as you were saying before, just hunker down for the darker months and make the most of it. Get a little more sleep, because it's pretty easy to sleep when it gets darker. Here we're a little further north, although Kevin, I think you're pretty far north where you're living. So, in the summertime when we do that time change thing, it's like 9:30 before it's actually getting pretty dark out. And you think, is it time to go to bed already? But it can be tough. So I think we can get our good sleep in now, right?
I heard a joke, David, you'll like, is someone said, it was somewhere around like 9:30 at night, and then I looked at the clock and realized it was only 6.
Yeah, exactly. Yeah,
right.
Yeah, it just sneaks up on us so fast, but here we are. So I've jumped into thinking about sleep a lot in the last probably 10 years, but as a pharmacist, I go a lot further back than that, focusing on psychiatric medications. I did my training in pharmacy as an undergrad at U of T and worked in the psychiatry department at a big hospital in Toronto for a few years, and then went to Boston and did a little bit of training down in Boston, and then went out west and did some more work, school work and training, graduate work out in Vancouver, a little bit further west than you are, Kevin. And then got a really great job opportunity with a person I'd worked with back here in Halifax. So moved across the country back to the Atlantic coast, so coast to coast, and have been working in psychiatry really ever since. And, you know, from day one, or really from undergrad days, we've talked about the overuse of sedative hypnotics for the management of insomnia. And with SSRIs coming along, we've really thought, why are we using benzodiazepines and Z drugs and other sedatives for the management long term for these disorders? So we've been doing well, I think, overall, but some places in Canada, especially the East Coast, we've got really high rates of sedative hypnotic use. So here I am trying to say we got to push those numbers down, especially in the older adults, because they can do an awful lot of things to us as we get a little bit older, and we can get a little bit more vulnerable to their adverse effects as we get older. And there's a better therapy anyway. So what are we doing?
Excellent. I think that's one thing I'd love to know a little bit more about your background, David, especially what drew you into being a sleep expert inside the field. You know, that's not something that I think most folks that think of a pharmacy background might think a sleep expert kind of component, which I love. And I think it really does go hand in hand. But the other piece that I'd love for you to kind of prep the audience on is, how big of a problem is insomnia?
Yeah. I would not ever describe myself as a sleep expert. I would describe myself as a pharmacist, a researcher. You know, I've done clinical epidemiology and community health, and really thinking about your community and your patient care. And, you know, to me, that's really a community pharmacist domain. They really think about both of those things, the community and their individual patient's wellness. And when we sort of think slightly one level above the individual patients, how healthy is our community? And when you think of sleep, like, we take it for granted. We know that we don't get enough sleep. We don't prioritize it enough. And that's something that there's an organization here in Canada, a research organization called the Canadian Sleep Research Consortium. And I'm part of that research consortium. And we're actually lobbying the government to put in legislative changes so that sleep becomes as well recognized as nutrition and exercise as a fundamental component of your health. And so when we think about all the things that sleep does, like, there isn't really one thing sleep doesn't do for our health. You know, it clears out the chemical cobwebs overnight so that we can actually have less toxins in our brain, so we can function well. It has something to do with our reproductive cycles. It has something to do with our immune system and our cardiovascular and metabolic health and our mental health. You know, the list is extremely long, and I actually don't know what it doesn't actually include. So we really do need to think about sleep as a critically important component of our lives, like 1/3 of our lives. And then when we think about insomnia is the most common sleep disorder by far. And if it depends on how you define it, but almost everybody's had an experience of insomnia. Not everybody's had an experience of chronic insomnia, but chronic insomnia, as we get older, it happens more often. And so somewhere in our midlife to later adult years, and then into our older adult years, we see somewhere between around 10% of individuals meeting the criteria for chronic insomnia. And how do we treat chronic insomnia? Well, we're not really supposed to treat it with sleeping pills, but that is the default across North America these days.
So, David, can you share with us the parameters between acute insomnia and then what makes it chronic insomnia?
Sure.
And even so, with that, how those treatments might change and
Yeah.
vary.
The latest language that from the diagnostic terminology is short term. And short term is if you have difficulties with sleep, which means you can't get to sleep fast enough, or you get to sleep and then you wake up in the middle of the night and you have difficulty getting back to sleep, or you wake up too early, like way too early, and you can't get back to sleep. So all of those are kind of like, okay, that's the insomnia part. And then it has to affect you the next day. So you have to be distressed by that lack of sleep that you've had the night before. Some people are naturally short sleepers and they get 4 hours, 4.5 hours, and they're not distressed. So that's not insomnia. It's only if you feel like you're distressed and it's impairing your abilities to do what you need to do. You might feel easily stressed. You might feel emotionally, I'm on edge all day, or you might actually feel like I'm making lots of mistakes, or I feel uncomfortable driving. Those are all of those kind of things that say, yeah, that fits with this being a true sleep problem, insomnia, and you can't get to sleep. You have to have that 3 nights a week or more. And if it's up to 3 months, or less than 3 months, we call that short term. But if it goes beyond that, the DSM-5 says that's called insomnia disorder. And if you're using an international classification of sleep disorders, then you would call it chronic insomnia. So they use slightly different terms that mean the same thing. So if you're over the 3-month barrier, which that's what I'm talking about, people transforming or transitioning from a short-term into a long-term, that 3-month is this kind of arbitrary cutoff. And they say, oh, that fits insomnia disorder or chronic insomnia.
So, David, I'm assuming, though, that people can almost go full circle, if you will, and perhaps gain better sleep, even though they might be acute or short term, if you will, and then chronic. And then can it circle back around that they're good sleepers again?
Absolutely.
So,
yes.
So basically, what I'm trying to get to is that the actual defined diagnosis, if you will, does not have to stick with the patient for life.
Absolutely not. And insomnia is one of these things where if you take a pill approach, you are not treating the underlying cause, and you're not giving yourself the opportunity to actually become a good sleeper. You are relying on a medication that actually, if you take it long enough and you stop it abruptly or you reduce the dose, you'll have rebound insomnia from a pharmacological withdrawal. And that'll make you go, oh, I better stay on these medications. So it has that reinforcing effect when you stop the medication either too fast or you're quite sensitive to the stopping of the medication. And so that's why a lot of people say, I need my sleeping pill. I can't sleep without my sleeping pill. You don't know what you're talking about. I can't sleep without it. And I said, I bet you actually can. Let's talk.
Yeah. So share. Oh, go ahead, Kevin.
No, I was going to say the same thing. Share, I guess, we could probably do an entire didactic that David could break down for us when it comes to each one of the medications that are kind of in place and what it does to sleep. But from just a general perspective, David, give us some ideas of what are commonly things that are prescribed for sleep, unfortunately for chronic insomnia as well. And what do they actually do to your sleep in a negative fashion?
Yeah, so I'm pretty broad in my definition of what is a sleeping pill, because it might not come in the form of a pill.
True.
Could come in the form of a bud, as a lot of people know. So sleeping pills are anything that is used to help people get a good night's sleep. And so we can think of that as prescription medications like the benzodiazepines and the Z drugs. So in Canada, Zopiclone is our big Z drug. And for you guys, it's a different Z drug. It's Zaloplan, I believe, or Ambien. I think that's yeah, Zolpidem, sorry. That's still your big number one, if I understand. We have some use of that, but a bit less. And then we have other medications that are not even indicated for insomnia, but that's okay because they're still sedating. And so we go, all right, so let's go to trazodone. Hey, that new antidepressant mirtazapine, that loves the histaminic receptors, and it makes you tired because it's an antihistamine first and foremost. And so at a low dose, people are taking mirtazapine by prescription, which is just like an antihistamine. Then there's the over-the-counter pills that are mostly antihistamine, sedating antihistamines. But some people have been using other medications, gabapentin. Of course, there's the new DORAs, or the dual orexin receptor agonist drugs, or antagonist drugs. So we've got a new class that's come along, and people are going, oh, but this is the breakthrough class. This is the drug class that's safer. It works differently. Therefore, it's going to be better. Melatonin is huge here. It's probably huge where you are as well. Other countries that I've been to, that they tell me it's a big thing. All the randomized control trials of melatonin in the adults with insomnia, it works as well as the placebo does in those studies, and it doesn't work any better. And we have good data on melatonin in other areas where it's helpful, but it's actually not helpful for where it gets used the most. And it's got great marketing, and people believe in it, and they get their information from all sorts of resources, if you will. And so we've got the medications covering a variety of different mechanisms, and then we jump into alcohol and jump into cannabis. All of them, some share mechanisms, some have unique mechanisms. But let me go back to what I said before. None of them are actually going to fix the underlying cause of why you now have chronic insomnia.
Yeah. So how does somebody fix that?
We just had a workshop this past Thursday with family doctors, and we had a sleep psychologist he's now living here, but he did his training in Oregon. And so we had him coming along with us to talk about it. And I did some content on the 3P model of insomnia, and he did some content on the 3P model. And I really like this model because it's relatively simple. So there's the factors that you're predisposed to. You're born with it. So you have genetic factors, biologically, or personality factors, which often are genetically passed along. And then there's the precipitating factors. And I would say that's where we've always focused. Did you lose a loved one or a job? Did you have to move? Did you have an injury and you couldn't sleep because of that, and so forth? So we really talk about that, and then we connect that directly to sleep hygiene. So you're not sleeping well because it's too bright, or the caffeine, or it's loud, or the bed's uncomfortable, or the room this, or you're playing hockey until 1 a.m, and then you're trying to get up at 6 and you're not being able to get to, like, all sorts of those kind of things relate to precipitants. They don't relate to predisposing factors. So that's the third P. And the perpetuating factors. The third P is perpetuating factors, because they're the one that keep this insomnia problem alive. And with chronic insomnia, they are the priority. So what is a perpetuating factor? All right, so let's think about, you have not slept for a very long time. What are you going to do? Well, you might nap. You might go to bed early and say, tonight I'm going to give myself the best chance of having a good night's sleep. And you're going to lie in bed and you're going to go, oh, it's happening again. I can't sleep. And then you're going to start to have that conditioned Pavlovian response. Oh, I hope tonight I get a good night's sleep. And if you start to say those words, I hope tonight I'm going to get a good night's sleep, it's almost like a recipe for disaster, because you're already worried about when you get into bed. And then you get into bed and you go, oh, I feel my mind starting to race. My mind is starting to race. And when you start to hear yourself say these things, you're aroused. You're not ready for sleep. They call it hyperarousal. So your brain becomes conditioned to be turned on, in part because of all of these maladaptive changes that you've made. And so you fragment your sleep. You're in bed for way too long. Your sleep is broken up with fragments. Every time you wake up, it's for way too long. You can't get back to sleep because your mind is racing and so forth. And then what do? I'm going to lie in bed a little longer. I hope to catch up on my sleep. So all of a sudden, your bedtime and your rise time are not consistent anymore. They're all over the map. And all of these things are perpetuating factors. So what can you do about them? Well, a sleeping pill is not going to train yourself to decondition those condition responses that you have when you're thinking about going to bed, when you're winding down and getting ready to go into bed, and you go, I'm going to do it tonight. I really am going to do it tonight. I'm going to click that off. Everything's perfect. And then your head hits the pillow. It's dark. And then, oh, tomorrow, what am I going to do? No, don't think about what I'm going to do tomorrow. It just starts happening over and over again. And people who are chronic have chronic insomnia almost all of them that I've ever spoke to say, oh yeah, when you said mind racing, that's me. That phrase right there is me. And I think that's a great phrase for us to know and use. It really resonates with our patients. They really talk about their mind racing and they don't know what to do with their mind.
Interesting. So would you say, I mean, because you have a psychology background along with sleep, when it comes to some of the disorders that we think of, when it comes to behavioral disorders, that are diagnosed, usually we don't lump, at least from a general practitioner standpoint, sleep in those same categories. But the way you just described it, David, very much so makes you think that some of this chronic insomnia related problems or acute could be related to a manifestation, very much so like an OCD, that you have something that you just continually have to go after and try to finish, or you overly complicate an individual process psychologically. If you had luck educating providers, pharmacists, et cetera, on thinking about treating sleep differently?
Yeah, I think for insomnia, the approach that we take is the recommended approach internationally, cognitive behavioral therapy for insomnia, which is this kind of group of different sleep enhancing mechanisms or techniques or components that are all kind of blended into a program overall. And so I think when you say, have you had luck? I think it's, have we had people say, I really want to give the CBTI a try? And I would say, absolutely. I think a lot of clinicians are tired of just saying the option here is pharmacotherapy. And where we see a little bit of stickiness is on both sides, where the clinicians are not quite comfortable yet with CBTI and explaining it to the patient and supporting access to CBTI. And before you've sort of had a little bit of experience with that, you feel like you're a little tongue-tied and maybe not exactly sure of yourself, and you don't want to look unsure of yourself. And so then you might default back to where you're comfortable, which is the sleeping pills. But the other side of it is talking to patients about reducing and stopping sleeping pills. So ultimately, what can we actually do there? So CBTI has almost the most evidence I've ever seen for any intervention. And, I'm talking heart disease and so forth. So on that website that you just showed, if you go down a little bit into the CBTI page itself, there's a link that shows the evidence. And we actually have probably over 100 citations in that link organized by indication. So Kevin, what I really think is important for people to realize is insomnia should be treated as an independent issue, regardless of the comorbidity. So if you have a physical health illness, say it is diabetes, you will be able to find studies of CBTI in people with metabolic disorders, diabetes, endocrine disorders. What if it's cancer? You will be able to find people who have done studies on CBTI in people with cancer, breast cancer, after cancer has been treated, cancer survivors. You will find it in people who have menopause, perimenopause, postmenopause, during pregnancy. You'll find it in people who have depression, anxiety, schizophrenia, and other psychiatric disorders, PTSD. So the comorbidity, when people say, oh, but my patient has pain, or my patient has anxiety, or my patient has, it's like, you know what? You will get better outcomes for their other health issues if they go through CBTI. And there's some recent studies that showed, should we give CBT for depression first and then CBTI? Or should we give CBTI first and then CBT for depression in people who have depression and insomnia? And the results show you're better to give the CBTI first because you get a bigger bang on both, including the depression scores. And this is where I go, I think I backed the right horse here. The CBTI approach for managing individuals who have an anxiety disorder or a depressive disorder, we really should be prioritizing our ability to support patients going through that. We don't have enough CBTI providers to get everybody into being able to see somebody and get CBTI. So fortunately, we've got great evidence to show that self-help approaches which we really emphasize on our website. So there's a part of our website called Sleep Well Recommends. And we've done the hard work. We've looked over what are the self-help resources out there for individuals, and we've picked the bona fide evidence-based CBTI resources. So if you feel like, I don't know anybody who offers CBTI, and even if I did, I couldn't afford it, I couldn't get access to it, they're too far, there's all of these reasons why you couldn't do it. You can get a book for $25. That's a CBTI program, and we've got them recommended. Or you can get it online. And just recently, we put 2 on there that I'm excited to just quickly mention. Mm-hmm. One is from the US, and it's available internationally. And one is from Australia, and it's available internationally. So Sleep Easy, like the letters easy, people can see it on our website. But that's the U.S. Veterans Affairs video-based CBTI program. You just register. Actually, for that one, you don't even have to register. You can just kind of go in and go through the program on your own. And the Australian one is really interesting because you can do it on your own. You just go in, you register, and you go through the 6 or 8 week program. Or your clinician registers, and they send you an email. I think it's called a prescription to their program, and it's called This Way Up. So I think if you just go up a little bit, you'll see it this way up. So it's Australian, but it's for anybody in the world, and clinicians can get their patients to sign up. And if their patients sign up, the clinicians can go in to their dashboard and see how each of their patient is doing within the program. They're not delivering the actual CBTI. They're just encouraging their patients to go through the CBTI, and 6 to 8 weeks later, hopefully they're getting near the end of it. And every now and again, you have sort of a touch point with your pharmacist, with your family doctor to see how you're doing. And the family doctor says, I'm really glad you've made it through here. I can see that your sleep's getting better, or you seem like you might be struggling with this part or that part. Do you have any questions for me? And the pharmacist might be saying the same kind of thing, or saying, do you think you might be wanting to talk about reducing your dose of XYZ sedative hypnotic, because this medication may not be necessary once you've gone through this program. And other people use CBTI as they're coming off their sleeping pills, or even after they've come off their sleeping pills, if they feel like they need something to help them with sleep. So it's kind of got great evidence to support it. That we've now got some great actual self-help CBTI programs that are out there and freely accessible. And of course, there are people who will need to see a sleep therapist to help with their insomnia problems and maybe other problems. But this is really brand new stuff. And there's so many great resources that are existing and available now.
It's amazing. So David, can you just give us like one example of maybe even the first step, if there's a step process for CBTI?
Yeah, so as I mentioned, CBTI has multiple components. Mm-hmm. And the mechanical ones that are just like, all right, you just have to change your behavior. So the first one that people do is they log their sleep using a sleep diary. And that way they can sort of see how they're doing. With some of these digital ones, that they get some illustrations of how their sleep is changing over time. So once they get used to logging their sleep using a sleep diary or some form of sleep tracker, then they get advice on what they need to do. So the first thing they usually are told is, let's get your sleep following a sleep prescription or some sort of set bedtime and rise time. And if you don't have insomnia, you can go to bed at different times. You can get up at different times. But if you have chronic insomnia, one of the best things that you can do is say, I have a set bedtime and I have a set rise time, and I am going to stick with that even on the weekends or the days off. Mm-hmm. And that one little change can have dramatic changes in somebody's improvement. And then the next step is to make sure that when you're in bed for one of 3 things: sleep, sex, or sickness. Those are the 3 things. If you love to read before you go to sleep, but you have insomnia, do your reading outside of your bed. If you're lying in bed after the lights go out and you're not asleep after 15 to 20 minutes, leave the bedroom. If you wake up in the middle of the night and you can't get back to sleep after 15 to 20 minutes, leave the bedroom. And people say, well, how am I supposed to know it's 15 or 20 minutes? Do not look at your clock. Do not expect your watch or some other device to tell you what to do. Just guess. That's the way it's always been done. CBTI has been around since the 80s. It's evidence-based since clinical trials have been in place since the 80s and 90s. Maybe it actually goes back a little further than that. And it's all been done without fancy watches or fancy rings. So it's just been your best guess as to this is about 15 or 20 minutes. It's probably time for me because I just feel like I'm going around in circles here. And that in and of itself helps to break that conditioned response of being in bed and being awake with your mind racing. You can be out of bed and go do something with a lamp that's kind of dull and do something like read Moby Dick, which is maybe not the most stimulating thing for you to do at night. Some people like to knit for a little while. Don't watch a screen. And I know that's really hard for all of us these days. So that's the first thing. And we call that stimulus control. Everything I just talked about is called stimulus control. Go to bed at the same time, get up at the same time. If you're lying in bed and you're awake out for 15 or 20 minutes, leave the bedroom. Don't nap. Really don't nap. Don't steal your chance for a good night's sleep by having an indulgent nap during the day, even if you feel tired.
Yeah.
Then the next big step, and I won't go into a lot of details, but I will say this is a really important part 2 or partner of that stimulus control is bedtime restriction therapy. So if I ask both of you, how many hours are you in bed typically versus how many hours are you asleep? People with chronic insomnia, I would take that ratio. I'd say sleep hours to in bed hours. Often it's like 60%, 70% if you do a ratio. So people are lying in bed for a long period of time and not sleeping. The time in bed restriction therapy, which is very effective, maybe the most effective component is, all right, Kevin, you just told me you've been sleeping for 6 hours and it's not enough, but you're in bed for 9 hours. So next week, you're going to be in bed for 6 hours. You're not going to be in bed for 9 hours. And this is going to be tough for you. The next week's going to be tough, but we're going to take that fragmented, frustrating time in bed, and we're going to consolidate it into a much better, more sleep-oriented time in bed that's got continuity and better quality of sleep. You probably will feel like you're underslept for a little while. But if you're doing better with your sleep, you get to increase it next week, your actual time in bed, usually by 15 minutes, maybe a half an hour. And if you're still sleeping well, the next week you get to increase it by 15 to 30 minutes. So it's slow, gradual process of getting your sleep back. And through that 4 to 6 to 8 weeks of increasing the actual time in bed and increasing your time asleep and improving the quality of your sleep, we see people say, I'm only actually getting 20 minutes more, 40 minutes more than I was getting before. But man, I feel so much better. And it's the continuity or that quality of sleep that improves so much. So people don't like it when we say you're only going to be in bed for this period of time, but it's, short-term pain really for months and years of long-term gain.
David, I like how you just stated you might only have like 20 more minutes or 40 more minutes of sleep. And when you look at sleep trials with medicine, often people are getting 20 minutes more of sleep, and that's considered successful on average. So could you just comment a little bit on that in between, the CBTI and, like you were saying, we don't want to use medicine first. Do you have some of those comparisons available just to show 40 minutes here using this kind of conditioning or reconditioning versus 20 minutes on average?
Yeah. Most of these studies, and then you throw them all into the systematic reviews, show that in the short term, sleeping pills and CBTI basically give you the same amount of benefits And when we think about the benefits, it's how quickly are you able to get to sleep, and how much has your sleep efficiency improved. That whole ratio of time asleep versus time in bed, they're kind of similar, and your total sleep time. And you might be surprised that sleeping pills and CBTI are not dramatic, as in they improve your total sleep time by a half an hour, an hour, an hour and a half, or 2 hours. Some people get that. Some people really get fantastic results. But the average person gets better quality of sleep and better ability to function the next day with less daytime sedation and improved daytime functioning with CBTI versus their sleeping pills. The big advantage, there's two, with CBTI versus sleeping pills. One is once the program is over, you're done, say it's 6 or 8 weeks, you're done. And then you do a follow-up at 3 months later, and then at 12 months later, and even 2 years later. And people show a consistency of the improvements in their sleep. So let's say they were having 75% sleep efficiency before the study started, and then they get to 87%, which is really kind of in that ideal window. They'll basically be there months and years after they're done the program. And with the sleeping pills, you go from, say, 75 to 79 or 81% sleep efficiency, say 6 or 8 weeks afterwards. And then you have to keep on taking those sleeping pills, or else you just go back to having your baseline poor sleep, and you don't actually get the same level. The other big, and for me, maybe the biggest concern, and why I'm so interested in this area, are the harms associated with the sleeping pills. So we don't see the negative cognitive effects. If you're 75 or 85, you're already very much thinking about how healthy is my mind and what can I do to make sure that my cognitive functioning is the best it can be. And one of the things you can do is not take sleeping pills. Those sleeping pills impair your memory and impair your functioning in terms of your cognitive status. Like, that is as clear as a bell. There are some studies showing that insomnia and sleeping pills are associated with cognitive decline. We want insomnia to be treated as effectively as possible. And we don't think that sleeping pills are the best way to do that for an overall healthy cognitive function or mind. And then there's falls, and then there's driving, and then there's a long list of things that maybe we don't even think about. So there's some studies on the most commonly prescribed drugs on pneumonia, as well as, it's related to COVID. So there's studies of, if you're currently taking a sedative hypnotic like a benzodiazepine or a Z drug, and you get the flu or you get COVID, your chance of complications and being hospitalized are higher. And those drugs actually have data showing that they affect our immunological system. I always thought it was maybe related to our coughing and clearing our throat while we're sleeping, and we're taking a CNS depressant, and maybe more bugs are getting into our lungs. But it's actually a direct immunological impairing effect that the drugs have. That's subtle, but there's enough of us that actually have that as a concern. So lots of issues with these drugs. The older you are, the more vulnerable you actually are to all of the issues with these sedative hypnotics.
That's so helpful, David. I feel like it brings me back rather quickly, doing my residency and then seeing patients. It was so interesting. We'd have patients that seemed really complicated, multiple comorbidities. You'd go into a household with a visiting nurses group, and you would think you'd be covering everything. And the entire time, the entire conversation was about sleep. Yeah. I can't sleep. I can't function. It is causing so many other problems outside of that. And as you mentioned previously with CBT versus CBTI in depression, I really wanted to highlight again for the audience. Oftentimes I feel like from a general care and a general population perspective, we think about sleep in terms of you either can or you can't. It's a problem that can be treated with a pill most effectively. And so when we go to the grocery store, you can't sleep. You look at something with a D in it, is usually for diphenhydramine or Benadryl, better known for that name, the brand name. or you look at melatonin, and you have those two things that are so commonly seen in medicine cabinets, throughout the US, and sounds like what David said in Canada as well.
Yeah.
The other problem is that instead of thinking of it being a psychological or mental struggle to be able to get to sleep, and we're not realizing we're almost programming ourselves that way, we think there's something chemically wrong with us, and therefore we need to correct that chemical imbalance with one of these other drugs that David has mentioned. So I'm so thankful you've kind of highlighted that piece. The one thing I wanted to tie together, though, David, is we've really talked about folks that they're just noticing they have problems with insomnia, and they're trying to choose between sleeping pills and CBT. How about for all those folks that they've already gone the sleeping pill route? And, all of us here know how difficult of a burden that can be to come off of those medications. But give us some tips for those folks that are saying, okay, I understand the problems with these sleeping pills. How can I effectively move myself away from these sleeping pills that have, like you said, it's a wide ranging, like sleeping pill could be bud, smoke, all kinds of things. How can they transition to a CBTI process or something that's going to be better long-term for them successfully?
Yeah, I think one of the questions you started off with earlier is, how do we give people hope? And when we talk about CBTI, it's, well, you may have struggled with chronic insomnia for so long, but don't give up, because there actually is a way for you to manage it and not be a poor sleeper, not self-identify, oh, I've always been a poor sleeper, and I guess I'm always going to be. You don't have to actually be that. And I don't have to always be a sleeping pill taker. So we just published a study in JAMA Psychiatry back in September. And the findings I'll just sort of summarize in a moment, but I'll tell you what we actually did. So we created a package and sent it by mail to our study participants. So there was two different types of package, and then there was a third group that didn't get the package until 6 months later. So one of the packages was Sleep Well. One booklet was really on how to get your sleep back, focused on CBTI, and one booklet was how to stop sleeping pills. And so the how to stop sleeping pills, the people in our study were all chronic sleeping pill users. The average age was 72, and the average duration of sleeping pill use was 11 years. So they were taking the benzodiazepines and Z drugs chronically for a long period of time. And the way we developed the booklets is it was very illustrated, and it was giving the same information that we've talked about, but in a slightly different way, in a way that was a little bit more direct. So think of, when you go to the pharmacy, you get the print off about the medication. It did not look anything like that. It wasn't something that just shared information on a white piece of paper with black text and maybe a couple of other colors. It was very illustrated, and it made very clear points about what you can do to get a great sleep and how to be reconsidering the overall benefit and safety of these medications that you're taking and how to safely come off them. So our approach is using a behavior change framework called the behavior change wheel. And within the behavior change wheel is kind of a collection behind the scenes of all sorts of behavioral theories. And we tied in with that the behavior change techniques resource. And there's an app that's available to all of us to use. All of this work really comes out of the University College London group that developed all of this. It's a fantastic overall way to think about the development of interventions where ultimately we're looking for behavior change, and that's a lot of what we do in our clinical practice, is try to help people choose the healthy behavior option as opposed to the current option that they may have. So we built in 29 different behavior change techniques of the 93 on the long laundry list of behavior techniques that have been trialed. And so that's a little bit of the background as to what we did. So these are all people, as I mentioned, who are in their 60s to 90s, been taking sedatives for a long period of time. And the Sleep Well group, receiving this package, we followed up with them 6 months later, didn't do anything else. They didn't contact us. We didn't, evaluate them every few weeks. We just let the booklets do the talking. 26% had stopped their sleeping pills when we contacted them. Just the booklets had led them 26%. The group that didn't get any booklets, it was 7.5% that stopped their sleeping pills. And so I like to use the term numbers needed to mail. We needed to mail about 5 booklets to get one person to actually stop. So it's a pretty equitable intervention. You can imagine there's no reason somebody wouldn't get this booklet if we could just send them out in the mail, maybe with some sort of HMO support or government funding to have everybody see these booklets. In the Sleep Well group, there was an additional benefit, which was better sleep outcomes. So people were able to come off of their sedatives, and whether you came off your sedative or not, your sleep got better. So we saw faster sleep onset by 25 minutes, whether you stopped your sleeping pill or not. So people were learning how to improve their sleep, even though they didn't stop their sleeping pill. And if they did stop their sleeping pill, everybody's going to be concerned, I'm not going to be able to sleep better. They actually slept as much, if not more, than the other group. Everything was a tiny bit better in the group that stopped their sleeping pill than the group that didn't stop their sleeping pill in that Sleep Well group. The other benefit was better daytime functioning. You were less sedated because you're sleeping better and you're off of your sleeping pill. So the main messages in that booklet were there's a bunch of harms that you need to be aware of, and you can go and talk with your pharmacist or your physician about these harms. And there is a safe way and an effective way to stop sleeping pills. And it's called lots of things. We call it gradual dose reduction. People often use the word taper, but we just call it gradual dose reduction. And that overall approach is designed kind of like a staircase, or I call it kind of a slow, bumpy slide where it kind of flattens out at the bottom, gets a little bit slower at the bottom. Most people can come off of long-term use of these medications without much of a problem. Most of our patients who actually came off of their sleeping pills in the study said, I didn't have a problem. And that kind of goes against what we've often learned and taught and shared with others is you can't stop this abruptly. It's going to cause you major problems if you do. Well, quite a few people went off of it a bit quicker than would be recommended. And you see how quickly it's recommended here. This is for the individual who does have problems when they come off of it. They've reduced the dose. And when they get near the end, they start to have some rebound insomnia, start to feel a little bit uncomfortable in a variety of other ways. And so we slow the taper down. But we really recommend that don't come off of it quickly. Come off of it if you've been on it for a longer period. For these chronic users, it's usually years. Be ready to do it over a minimum of 3 months and maybe 6 months or longer. And if you go to our homepage on our website, there's a couple of stories. We've got George, who Donna you met, and we've got Faye, who tell us about how they actually did it. So don't listen to me, listen to them. These are individuals who are in their 70s and were taking sleeping pills for 35 and 40 years. And Donna or Faye wasn't in our study. She just heard me talking at some presentation, asked me a couple of questions and looked at her friend and said, I'm doing it. And she just said, I'm not taking these sleeping pills anymore. And she figured out with her pharmacist and her physician a program that worked well for her to gradually come off of it. And then we interviewed her, and I couldn't believe what she told us in the interview.
I loved listening to George speak about how great he felt. And in the stories, like you said, that interruption during the day, not only was he taking sleeping pills and not necessarily sleeping great, but he was so groggy throughout the day, whether it be from not sleeping or whether it be from the sleeping pills themselves that were keeping him groggy. And I remember the one story he shared is, going to this meeting and trying to like fight through this early morning meeting, if you will. And then he would pull somebody aside, one of the administrative assistants who are sitting and taking notes, and saying, can you give me the abridged version of this meeting? I have no idea what I just sat through. And, a successful business person, but he was struggling for sure. Yeah. So like, that is just so amazing. And the fact that he just wants to share his story so that everyone gets off of sleeping pills and do this other program, the CBTI, because it was such a profound effect on him and impacted him so amazingly that he just wants everyone to do it.
Yeah, he's quite the ambassador.
Yeah, it's great. It's important for sure.
Do you feel, David, there is an opportunity, or is there a place in medical treatment acutely for us to use safely sleeping pills? Or do you feel like there is oftentimes, majority of the time, a better option like CBTI or another therapy?
I get that question a lot. So the guidelines currently say for chronic insomnia, it's CBTI, and they don't quite say for shorter insomnia, it's CBTI. And so when I get the chance to ask the sleep experts around the world, I say, what do you think of using CBTI when it doesn't quite meet that threshold? They go, oh yeah, absolutely. But right now, I think everybody's comfortable putting out front in guidelines if it's chronic, because there's a lot of people with chronic insomnia. We know it works well. And we've got studies hand over fist looking at chronic insomnia. Sure. But every psychologist that I've ever spoken to, the ones that actually have written the guidelines say, oh yeah, I use it all the time for people who have insomnia that's shorter. But let's go right down to the super short situation, like somebody who has just been hospitalized and they have not been able to sleep in hospital, or they have not been able to sleep because they are going through some sort of personal crisis. No. There are places for sure that we need to be able to step in from really to take away suffering that people are experiencing and give them just the ability to have 6-7 hours of a good night's sleep that they have not been able to have. So there's a few different scenarios we could come up with that. But ultimately, it's when somebody walks into a family doctor's office and says, my dog just died, or my family member has died, or I don't actually know why. Maybe it's this or maybe it's that, and I haven't been sleeping. Once that sentence ends, we should not be going, I am going for the prescription. I know what I'm going to be doing. You don't have to say anything else. If we can take away that reflex and say, okay, well, let's see what you can do. Let's talk a little bit about your bedtime routine right now. When are you going to bed? When are you getting up? Is that varying a little bit from night to night, day to day, over the weekend, and so forth? Let's talk about some sleep hygiene things that you can do. And I want to see you in a week or two, whatever fits the schedule for everybody, and see how that's going. And by the way, when you go, I'm going to give you this sleep diary, and I want you to log your sleep using this sleep diary. I am working with you. I am doing something with you. I'm not ignoring this. I'm validating this as a concern, but I'm not giving you a sleeping pill. So that's one option. Or the other option is I am giving you a sleeping pill, and I'm going to let you know that quite a few people, maybe 25%, 1 in 4, end up taking these for decades who start on them. And I'm not the kind of person that wants that to happen. But circumstances, at least across practices in this city or in this town, it does happen to some people. And I can't predict if it's going to happen to you or not. It's not going to be our plan, but I'm just going to say that happens sometimes. Is this something you want to do? And I'm only going to prescribe you 4 pills for you to go home with and see if it can get you through this. And I'm also going to send you to the Sleepwell website or something that you can start to figure out some of the actual techniques that are actually going to help you. But I am going to help you for tonight, and maybe over the next 2 or 3 nights that'll help you get a good night's sleep. But I don't want you to come back and have this conversation. They really helped. I want more. You can come back and we can have the conversation. They were that Band-Aid to get you through a few days. And now let's talk about getting a good night's sleep with behavior changes. And so I'm not saying absolutely never, but one option is we don't give the sleeping pills and we start with the behavior changes and we look at that. Or the other is a very, very short supply and say, we just don't want to run into the long-term user situation. And let's talk already about the behavior changes.
Yeah. It's like that new way of writing prescriptions and saying, you know, this is for an indefinite period of time for some issues, right? But we're always going to be reevaluating too, and how it's so important to have that conversation of this isn't meant for the rest of your life necessarily. We want you to make healthy changes accordingly. I think that's so important, and really looking at that very short period of time and, as needed, not
Yeah.
the every night for 3 nights even, like, let's just do this tonight, and then if you need it again over the next week, you have another 1 or 2 to help you out.
Yeah, I think the reality is it's tough. Like, it's really tough. We've got a history worldwide where we tend to use these medications thinking they're somewhat benign. So, a lot of patients have told me my doctor has me on the lowest dose and on the safest sleeping pill. And when they say that, I don't know what sleeping pill they're going to tell me, because I don't know what's the safest sleeping pill and I don't know what's the lowest effective dose, but that's the conversation that they've had to justify to themselves. We're doing everything okay. This is just fine. So I really think it's important for us to change the conversation a little bit from that, so that we have people understanding this is not the long-term solution.
Yeah.
Look over here. The long-term solution is over here, and it's more accessible than it ever actually has been.
Right. And it lasts longer.
Perfect.
Yeah.
I think the other pieces that David will add on there, and you please expand, is I feel like we too often encounter one of those acute situations you mentioned and then fail to ask about screen time and alcohol usage in those two spaces and how they can both impact sleep so dramatically. The other piece that we just had one of our listeners, and I'll throw it up on the screen so you can read it here, asked, pharmacists counsel to sleep hygiene regularly. Do you think we have a role in CBTI as well? Can you share what you see as the difference between the two? So the one thing, David, to frame that a little bit is you did mention the ability to be able to give something to a patient, right? We talked about that antibiotic stewardship quite often. And you have a parent that comes in rather worried that their family member has something going on and they feel like they need something, and we can prescribe something, or we can try to recommend avoiding the prescription in general. The problem ends up being right there in the office that they want something to go home with. And I think the ability that you mentioned previously with having an application or a software to say, I'm prescribing this to you, is a really interesting next step for a lot of clinicians. Can you frame that inside of this question on how we could potentially use a software application in the pharmacy space?
I don't know. We'll see what I can come up with. The question makes me think of one of the tools that we've recently sort of reorganized, and it's represented in a slightly different way, but it's perfect for this question. So it is CBTI the same as sleep hygiene? And the answer is no, it's not. All of the research on CBTI, not all of it, but almost all of it, uses sleep hygiene as the control group. And the reason is, for people with chronic insomnia, sleep hygiene doesn't work. So I want us to really take this home. Sleep hygiene's role is for people who have short-term insomnia. That's where sleep hygiene can be something we have a really good conversation around. If we keep on talking about sleep hygiene months and years into somebody's chronic insomnia, we're wasting their time and we're wasting our time. That handout has examples of what CBTI actually is and how it is not sleep hygiene. So we really got to separate out sleep. Sleep hygiene is a component, and many of the psychologists that are the sleep experts will tell you it is the ineffective component of CBTI. It is not going to help people who have chronic insomnia, but it is going to help people who have short-term insomnia, and you can work with them on that. So keep on talking about sleep hygiene for those individuals who right now have just developed insomnia, because maybe it's caffeine, maybe it's late night exercise, maybe it's screen time, maybe it's a few of those things that are a quick fix. But for somebody who has maladaptive behaviors and they have conditioned hyperarousal, we need to use CBTI to undo all of those cognitive and behavioral changes that have over time. And the question that I'm really interested in, do pharmacists have a role? Absolutely, we have a role. Like, I think pharmacists have been talking for a long time already about stimulus control. Go to bed at the same time, get up at the same time. If you're not sleeping, get out of bed, leave the room. Only use your bed for sex and sleep and sickness and those kind of things. Pharmacists probably haven't traditionally been talking about sleep restriction techniques, but they can support somebody who's in CBTI to say, all right, so you are having some recommendations through your program about really reducing your time in bed. How's that going? Oh, it's really tough to do. I hear there's a bit of wiggle room. If you can't quite go all the way down to 6 hours, do you think you could do 6.5 hours, 6 hours and 45 minutes? I know that's the recommendation from your program, but like, if you just can't, get close, but in a way you're actually comfortable with it. And then there's cognitive components, another component. If the pharmacists are familiar with the program organization and the overall components and what they do and how they work, pharmacists can be there. Maybe coach is a bit of a strong word, but it's really coaching and supporting the person through the program. When somebody says, I'm struggling with, when it's a medication, what does the pharmacist do? The pharmacist often says, you're doing great, and uses an approach where you're really building on the strengths of what the person is doing. And you can do the exact same here. You can say, well, you already did your sleep diary for the first 2 weeks. That's fantastic. And you did the stimulus control stuff already. And you were getting out of bed in the middle of the night, no matter how cold it was and how hard it was. You told me that. I think you're doing great. I think this is going well. And I can see by your sleep numbers and what you're saying, even today, I saw you walk in, you look brighter, like that kind of stuff. I think this part that you're in right now, this restriction time in bed, it is the toughest part. Once you get through that and you get to extend it out a little bit, I think you're going to find it was a worthwhile thing. You can say things like that. You can talk about relaxation therapy techniques and say some of them are not for everybody. Like, some people, they lie in bed and they do the progressive muscle relaxation techniques, and they start at their toes, and then they start on the left side and they work their body up their body, and then down. You do it different ways. It's all distraction. It's just to relax your muscles and distract your mind so that you're not thinking about what you said to that person earlier today, what you have to do tomorrow, if your son's going to come home on the weekend or not. Like, you're no longer thinking about all those things. You're thinking about, what's the next muscle beyond my calf? Can I actually squeeze the next muscle beyond my, oh yes, I can. There it is. It's boring. It's not all that interesting. And it helps with you just to say, oh, sleep is starting to take over and I didn't even try. So that, like, we need to say, if that one doesn't work for you, there's another one I know about, or another one I know about, or go to this website, or go to this book, or go to this app, and they're going to teach all of it to you. And if that app is not the one you like, try a different app or try a different book. What we need to do is identify people who say, I tried CBTI and I didn't like it, or it didn't work for me, to be able to say, tell me what you actually did. What did you do when you did CBTI? And if they go, oh, I cut caffeine out, and you'll go, oh, you did sleep hygiene. You didn't do, you won't say it like that, but that's kind of, sometimes people will say, oh, it's that, sleep hygiene stuff, right? You go, all right, maybe not. Maybe we should talk a little bit more about CBTI. Or they tried CBTI all on their own, and maybe they need some sort of CBTI with support, or maybe they need CBTI in person. It's kind of like saying, you tried a sleeping pill and it didn't work perfectly. I guess you shouldn't try sleeping pills anymore. There's a whole host of different types of formats and resources and techniques within the CBTI. A lot of people say, I know it had these 5 components. I tried 2 and my sleep was amazing. Do I have to do all the other ones? No, you can pick and choose components of CBTI. And as your sleep gets better, you don't have to go, okay, now I got to finish this program off. If your sleep is getting better, just get good at the ones that work well for you, so you can adapt it to your needs.
Awesome.
Excellent. Yeah, it's extremely helpful. I think that the episode on me absolutely flew by, David, because you just packed it with so many kind of components that I feel like are so valuable for both clinicians and patients to recognize that sleep doesn't have to be a one pill fits all, kind of solution. And there's so many other options and so many reasons why those other options should be explored early, but don't necessarily have to be done just in the very beginning. There still is a ton of hope for those individuals that have been on a sleeping pill to make those changes necessary to get better sleep long-term. And the only thing I have left, David, is just how can folks reach out to you? How can they find out more about the work that you're doing, and any other last messages for the audience?
We try to make it so that there's one site to fit all your needs for insomnia. So mysleepwell.ca, we're really trying to help people who are long-term users of sleeping pills say, I can transition off being sleeping pills and be a great sleeper, as well as people who have never thought about using sleeping pills, but they just struggle with insomnia. And so both of those groups of individuals can go to mysleepwell.ca and really look through the content that we have there. And you've already shown a few of our resources, which are really intended to be handouts to patients or handouts to family members or for yourself, and say, let me reassess CBTI versus sleeping pills, or what is actually CBTI. We have a handout on that, or we kind of compare CBTI with sleep hygiene. And then we've got a section on insomnia. What is insomnia? What are some of the myths associated with insomnia? You can test yourself against that. We've got some, what do you know about CBTI? So question and answer kind of thing. And the same with sleeping pills. And then we got the dangers of sleeping pills. And I think that attracts a lot of people. So we're trying to give people answers to what they need. If you're a clinician, on the clinician page, there's 4 videos. They're meant to be really short so that you can get to know what's on CBT, on Sleepwell, and know how to quickly use it to help your patients in different scenarios. So there's more to come on Sleepwell. We've got the booklets that were used in our study. We're going to have our, I guess we're going to call it resource center, so people can actually get access to the resources that we've tested in our research and be able to use it themselves.
Amazing. Amazing. Donna, any final words?
No, just a big thank you. Thank you so much. And hopefully folks will be resting easier after listening to this and being able to help family members, as we know that many caregivers listen to us too. So caregivers alike can also be empowered to help their loved ones. So can't thank you enough, David. And there is so much to be learned, but like you said, there's hope. And I love that, because it is the season of hope right now.
I love it. Well, go ahead, David.
I just want to say thanks so much for having me on, and this is a great time to get to know you, Donna, a little bit better. And Kevin, thanks so much for the opportunity to meet you and chat with you about this kind of stuff. It is getting colder out there, and we're spending more time inside. Only go to bed when you're tired.
Yes.
I love it. Good wise words at the end there. Everyone have a wonderful, restful night.